I've met many or most of you. My name is David Limbrick. I'm one of the pediatric neurosurgeons here. One of my absolute focus areas is Chiari and Syringomyelia, as most of you know. I just want to say thanks for coming today and welcome. First of all, I think we have to acknowledge Dorothy's commitment. Can you imagine? She hasn't. I think she probably went to most, if not all, of those walks across the country. So you can imagine a different city every week, basically.
Well, Kathy does too. So
yeah.
I divide the load up, but I did the majority of the lectures, and I did many of the walks. She did 2 thirds of walks. So.
And she's gone 2 or 3 days for each of those, and that doesn't include all the national meetings that she hosts that, for example, at the AANS, which is a neurosurgery meeting, and the CNS, which is another neurosurgery meeting, and various other fundraisers. So her commitment is exceptional and totally impressive, and I want to say thank you for that. And then others in CSF, and that includes Kathy, who has been here on previous events, but wasn't here today. Isn't here today. And then Caitlin Esposito, who helps to run on the ground, sort of remotely, but also attends many of these. Who I just learned last night is getting her master's of public health, and we're hoping to keep her in the Chiari community. So she's not here, but I do want to acknowledge everything she's done. And then Matt Brewhauser, who's in the back. He does all the video recording and uploading and editing. He has recorded each one of these lectures that we've done here, which again you can find in the library on the CSF site, and really a fantastic job. He catches my bad angles all the time, but anyway, thanks for making the trip once again. And I want to say thanks to the local chapter led by Jennifer for everything that your commitment in setting up the walk and everything you do for us again on the ground here in Missouri. So thanks to everybody. I also want to say thanks to Catherine Richard, who's here. I don't know if she had the opportunity to introduce herself, but she works in our office in neurosurgery, which is exactly 1 floor up from here. And she helps us to coordinate many of the clinical studies that we do out of our office. And if you didn't know, we have I think a strong clinical research program, and help to coordinate many or several of the national and North American research studies in Chiari and Syringomyelia, and she leads those. So I want to say thank you to Catherine. I also want to say thanks to Marcia, who's not here, who helped kind of put together many of the details today. And finally, in the Department of Neurology here at St. Louis Children's is Chris Gurnett, who has been at these meetings in the past and is running a genetic study so we can determine the genetic causes why you develop Chiari and Syringomyelia. And her right-hand person out there, who's Tim, who may have approached or even drawn blood from you today. So he's out there. I do want to thank him. He's been fantastic. Part of what we do as one of the grants that we obtained from the Patient-Centered Outcomes Research Institute, or PCORI, which Dorothy referenced earlier. So PCORI supports a lot of our work here, and one of my duties as the principal investigator of that grant is to give updates to the community from time to time. So I'm just going to tell you a couple details about the study, this so-called posterior fossa decompression study. And this is a randomized study. I did want to just point out that several of you in the room, without naming names, supported that study by writing letters of support, really heart-wrenching letters of support of how Chiari and Syringomyelia have affected your lives. And this has been fantastic, and it is a large part of why we were able to obtain almost $3 million to study this disease. So I want to thank you personally for that. So right now we're running a clinical trial that involves, as of today, 28 different major pediatric hospitals across the country. And this is sort of ground zero. In fact, Catherine's office is sort of ground zero for that study. Our goal is to have 40 total. We've invited 47 centers to participate. It takes a long time to get the human studies protection parameters approved, and so and every institution is slightly different, so others are coming on board as we speak. But this is a 3-year study, and we've already made great progress. We've screened across the country 161 patients for this in the short time that it's been up and running. And we've enrolled 23 patients who make all our criteria and have actually had surgery already. So our goal is to have just about 240, so we're about 10% of the way there, which is fantastic. And again, the reason I point this out is that these clinical research studies that we do are, I know you understand, of course, our goal is to define why exactly you develop Chiari and how best as clinicians we can treat it. And that means how best we treat it with surgery. If people need orthopedic surgery for spine deformity or other problems, how we manage it from the pain management standpoint, all these things are part and parcel of this. But so the grants and the studies are all directed for you all who are affected by the disease, and for us as clinicians to know how best to do our job. But we couldn't do it without you. So these studies are really your research studies, so I want to thank you for that. Also, out of our office and out of Catherine's office, we run something called the Park-Rees Syringomyelia Research Consortium, and several of you in the crowd have actually ran fundraisers for that and donated your time and money for that consortium. So again, thank you. We have 1,200 patients in that now, and we're mining that data. So just this month, we have a paper that's been published or will be published this month, looking at the joint between the head and the spine and how that the anatomy of that joint may foretell how you're going to do with surgery. We have another one that's in preparation now, but is already presented at a national meeting where we look at how it affects spinal deformity. We have a number of other papers in the past that have been based on this data as well. So again, I want to say thanks to you. Everything you're doing is helping to teach us as a community of clinicians how best to take care of patients with Chiari and Syringomyelia, so thank you. And then lastly, Tim, who's out there, is collecting DNA, and I'm sure he already has collected blood and other samples from many of you, so thank you for participating in that as we look for the actual origins of the disease, so thank you. So it's my distinct pleasure to introduce the speaker today, Jacob AuBuchon, who went to both undergraduate and medical school at UMKC, just across the state there, and came to Washington University for his residency in anesthesiology. Afterwards, he did a fellowship in pediatric anesthesiology and pain management. And he joined our faculty several years ago to specialize and lead our programs in pain management, pediatric pain management. And he's, as a neurosurgeon who takes care of these problems, he's become the go-to guy here for me to send patients, but he's been fantastic in helping my patients, and I'm really excited to hear him talk about his strategies for pain management. So without further ado, Dr. AuBuchon.
Thanks. Well, first I want to thank you all for inviting me. I think this is a great venue to do this, to get actually patients in here with hopefully a lot of good questions at the end of the talk. I didn't design this as a 3-hour lecture or anything like that. It's going to be hopefully fairly high yield for you all, and only about 20-30 minutes of me talking and then some time for questions. A little bit about my career. So I was drawn to pain management in general because I thought especially in the St. Louis community, we always could do a better job managing pain. And even specifically with pediatric pain or childhood pain, it's poorly understood. Many of you, especially the adolescents and the teenagers in the audience, have probably realized, especially with some of these painful disorders, that there's a negative connotation in the medical community. Often you can't see the problem that actually exists, even though it's causing a lot of pain. And that's really unnerving for the person suffering in pain because of the misunderstanding of even medical providers and the disbelief that something's actually going on. But from my standpoint, I know something's going on, and we're really here to help. So I do not have any financial disclosures. The general overview of the talk is it's hitting a lot of aspects of pain in general. I do have a few slides over EDS specifically, over Chiari and Syringomyelia, but most of it is geared on our general pain management approach. And we apply it to many different types of pain, but we treat everybody uniquely. So depending on what their biggest type of pain or most difficult part of their life, that's what we're going to focus on and help with that. But in general, this is just hitting the surface of most of the strategies in managing pain. We'll talk somewhat about the types of pain, the treatment strategies and the difference between short-lived pain, especially around the time of surgery, but also more importantly, long-standing or chronic pain, which is what most of my job is focused on. I spend about 50% in the adult realm doing adult pain management and 50% in the pediatric realm where I focus on long-standing pain in children, but also help with pain around the time of surgery. I have a few slides over EDS, or Ehlers-Danlos, which we know has a strong correlation with both Chiari and Syringomyelia. And then I can't end any talk, it seems like, in the last couple of years without talking about the issue with opiates. And hopefully I'll be able to say why the media's ramped this up and why over the last few years we've really de-escalated the focus on just using opiates as the primary way to control pain. So, what is pain? It seems like a simple question, but every time I've been explaining this to a medical student, it's often really hard to explain. And I guess it's good that it's difficult to explain and to treat, because if it was really easy, I probably wouldn't have a job. So at least because of its difficult nature, it keeps me very busy. But the plan, and this was by a big group and organization called the International Association of the Study of Pain, back around 2010, 2011, described it as this: an unpleasant sensory and emotional experience associated with actual or potential tissue damage are described in such terms. I really care mostly about that first line, because to experience pain and to have that discomfort, it's got to go from a nerve to the spinal cord and then up to our brain. And that's where we experience pain, in the brain. And the reason this is important, first, as we developed as humans, we needed our brain to adjust from a painful condition. If we get a broken arm, and this is primitive times, we break an arm and we're just debilitated and we fall down, we have nothing to help us deal with that painful condition, well then the human race would have never developed. We would have been extinct pretty early on, because we wouldn't have been able to adapt to that painful condition. So we have mechanisms in our own system and in our own brain to help us deal with these painful conditions. It also, by it being processed in the brain, you can see that emotion always plays into this and really can perpetuate a painful condition. I think all of us have experienced, if we have a rough day and we get home and we stub a toe or hit our elbow real hard, it always hurts worse than if we had a really good day. And I think we all have had that happen. It just goes to show you that these aren't two separate things. Emotion, mood, and pain are intertwined. They're not totally separate. So we shouldn't treat them separately. We should treat them as a whole. So types of pain and what the patient experiences is really important to me. Of course I care about the underlying origin of the pain. I want to try and treat that if there is something definitive, a surgery or something to fix something, a broken bone that needs to have a surgery to fix it. Of course we want to focus on that, but especially for long-standing pain, I start caring more about how the pain's described and what type of pain I think it is. So when we talk about pain, these are kind of medical jargon words, but nociceptive and somatic. What that means is somatic pain is what we typically think of pain. We cut our finger, we sprain an ankle, we have a surgical incision pain. That's sharp, easily pinpointed pain. You could cut your finger and not have to look down on it, that you know that your finger's hurting. Visceral pain is more of like pain associated with our intestines and our liver and our organs deep down inside. When we have pain there, you really can't pinpoint it. You can't say, oh, it's this part of my small intestine that's hurting. It just feels like general abdominal pain. And we've all had abdominal cramps, usually from a viral illness, and so that's another type of pain. Neuropathic pain you will hear diabetics frequently have this type of pain, that burning electrical sensation, pins and needles in your feet. Also, if you hear the term sciatica, a pinched nerve in your back, pain radiating down your leg, that usually feels like pins and needles. And most of us, at some point, especially as we get older, will experience some type of sciatic symptoms. As somebody that has experienced it, it does feel electrical and numbing and pins and needles. Again, the importance of these types of pain, they really change how we focus medical management and other treatment strategies. Inflammatory pain is another type, where we focus on anti-inflammatories at first. So we sprain an ankle again, or if we have arthritis in our knee, especially if it flares up, we take over-the-counter anti-inflammatories to calm that down. But inflammatory pain is present with many injuries, including surgery, and basically anything we do at all that would tell our body that it needs to heal. The inflammatory response is our body trying to heal that injury. So specifically, when we see patients with Chiari, and when you first present with Chiari, you guys know better than me if you've experienced it, but it's worse with coughing and sneezing and straining often. You have pain often at the back of your neck, or sometimes numbness and weakness when you strain or cough or sneeze, or commonly you have headaches. Now, headaches are really tough at first to differentiate whether it's Chiari or a migraine headache or a tension type headache or a chronic daily headache. And that's often why they start trying to treat with medicines, and they try and treat the headache type, because it's of course much more common just to have these headache types than it is to have Chiari. But the important thing is, if the headache is occurring and not getting better with any of these traditional headache therapies, well then probably need to seek help from a neurologist if that hasn't yet, and probably would likely need an MRI. I'm not the expert in the room about diagnosing Chiari, but that's typically the way that it goes. I show this picture, and I may say it a few times, of the one in the bottom left-hand corner. I blame the trapezius muscle for a lot of things, probably more things than I should, because I think even though the origin of pain may be deeper, a lot of what I see is a response of muscle pain, and commonly either after Chiari or even before, or even specifically with Ehlers-Danlos, these muscles may be a big generator of pain, and that also focuses the way we treat patients. Some pain associated with Syrinx. Honestly, this is probably a very small part of what I see, painful conditions associated with the Syrinx, but typically it would be pain and temperature would be affected, abnormalities in that sensation may be asymmetric, and classically it's a cape-like distribution, but this is highly variable. So how do we treat pain around the time of surgery? And it is different how we treat this acute pain, or pain that we expect to be short-lived, versus pain that we would treat more chronically or long-term. For short-lived pain, and especially short-lived severe pain around the time of surgery, after a big spinal surgery or even a Chiari decompression or other repairs, opiate pain medications are still one of the gold standards of treatments. It's one of the main things we use. But the important things are to realize is they do have side effects, even in this acute or short-lived realm. They cause constipation, which also often slows your recovery after surgery. They can, at high doses, they can start decreasing your breathing if you're not used to taking these medicines. So the things that are listed below these medicines are in order to, one, limit the side effects of opiates by taking less of them, but also boost the good effects of the pain control in general. So Tylenol, I would not expect that if I gave anybody Tylenol after a major surgery that they would be very happy with me. If I did that, I probably wouldn't be speaking in front of you today, because I probably wouldn't have a job. But if we give Tylenol with these medicines, it boosts up the effects of the opiates, and when it boosts up the good effects of the opiates. So it's by doing that, it limits how much you need, and limits the side effects. I should have said when I mentioned opiate pain medications in general, that's morphine-type medicines. That's medicines like Dilaudid, oxycodone, all those medicines. Tramadol is even somewhat of an opiate pain medication. So those are the ones that I'm referring to when I talk about opiates. The other things we use is muscle relaxants. What we're trying to do with muscle relaxants and nerve pain medications is we're trying to work on different receptors or parts of the body So we're not just hitting the way these other pain medicines work. We want to do a mixed bag of the way things work so we can get better pain control. With surgery in general, we often can use what's called regional anesthesia. So everybody will get a general anesthesia for different types of surgery, but we can often use nerve blocks and things like that for specific type of surgeries. With Chiari decompression and surgery for Syrinx, it's just not very common to do those, but those are options for other types of surgery. So most of my job is spent helping managing chronic or long-standing pain. And there's a different focus with dealing with chronic pain than there is dealing with acute. Our bodies are designed to deal with acute pain pretty well. We know if we hurt something, what do? We rest. We break an ankle, we rest, we let it heal, and then we start kind of rehabbing or getting back to our normal lives. But if we use that approach and that mentality with long-standing pain, it will really limit what we can do for the rest of our lives. So if our bodies are telling us it hurts, so I shouldn't do it, what happens over time is those muscles that support our entire body and the sensation of normal response, it starts inhibiting us from progressing. And so the more that we don't try and live a normal life, the weaker we get, and therefore when we try to do something that we once could do very easily, now it's painful to do. And that, you can see, that's just a vicious cycle. If we're not trying to work on strengthening and getting back to our social life, in the end it's just going to lead us to a much worse place, and we're going to be more disabled afterwards. So the different categories we treat from to try and capitalize on that and help patients out are, one, physical therapy. And I'll say physical therapy frequently throughout the next few slides, but what I really mean is a physical therapist as an instructor to give you an exercise program and a way to gradually boost back up to a normal way of life. So really the best treatment is the program that they give you to take home and that you can use on a daily basis and for the rest of your life. So physical therapy, specifically seeing a physical therapist, is just the tip of the iceberg. The really focus is we need your help to get better, because if we're not having the patient help us out by exercising and increasing their strength, then we really won't make much progress. The other categories are psychological therapies, which I'll mention in a minute. Sometimes we do injections or nerve blocks for different types of pain. Of course, medications, I'll mention a little more in a bit. And then surgery, I always put that on there because there is sometimes definitive surgery or very helpful surgery depending on the disease state. So physical therapy, what we're trying to do, the basic approach is we want two different types of exercise programs. We want one exercise program to work on aerobic exercise to increase your stamina so you can gradually build up and live a normal life, or at least a normal life with modifications. The other part is focusing on a specific area, especially for Ehlers-Danlos. If you sublux a joint and you have pain in that joint, well, we want to focus physical therapy over that joint for at least the short term to get you back on track, and then work on general things as a body as a whole. I also want to work on stretching to improve this muscle tension that I think is a big origin of pain. Working on posture, bracing, and appropriate taping. We never want to get in a spot that we're taping or bracing something like a joint for all day long, every day at night, because when we take off that brace or tape, then our muscles are weaker than they were to begin with. And of course, general conditioning. I also want to point out that by saying this, I'm not telling people that starting a day you're going to start training for a marathon. We're not pushing people too fast with this. We want to start actually very slowly and build up gradually, because anybody that's experienced pain, that's stuck around and they've lived with for a long time, knows if they feel good one day, what do they want to do? You want to get back to the stuff you've been missing out on. And when you push it really hard for one day, you'll crash for a few days or a week or maybe even longer. But if we build up slowly and gradually, then you're going to be less likely to have these flare-ups and less likely to have these crashes. So consistency is the key. And it's also important that even on bad days when the pain's significant and it's really slowing you down, to try and do something and to have established goals to build up gradually with these goals. Because I think if you do that for a few months or 6 months or a year, you'll look back and you'll be in a much better spot. But physical therapy, of course, is not the only treatment. Like I said from the beginning, there's not one magic treatment that we can give to fix everything. It's really a combination of these things. And psychological treatments are one of those other important things. This is probably the most difficult thing I have to explain, because when I start talking about this, people assume what I mean is that I'm saying it's derived from emotion or mood. That's not it at all. Like I said, pain's an emotional response, and we know when our pain's bad, anxiety, stress, and our mood's worse. And when our anxiety, stress, and mood are worse, our pain's worse. And so we can really capitalize on improving pain with these therapies that don't have side effects. You know, the cognitive behavioral therapy, which is a type of psychological therapy, doesn't have any side effects and has some of the best evidence, more than medications, for headache treatment of all kinds. The main purpose of using these techniques is to get away from the negative thinking. We all have avoidant behavior when something has previously, some activity or something we've done has flared up the pain. So whether that's sitting in class and muscle tensions building up and headaches are getting worse, our body tells us that we should avoid that. What this type of therapy focuses on is trying to work through that negative thinking that makes us avoid it, and working on more on positive thinking. So this can improve social interaction through school and work, but also family relationships. So medications, we do prescribe quite a few medications for different types of pain. All medications, even Tylenol, there'll be a big list of side effects. But the medicines that we pick are ones that are very well tolerated in general. For the individual person, there may be some side effects. Usually the most common one is drowsiness for many of these. But we're picking ones that are safe in general and have few interactions with other medicines. So those ones that broke up in a few different categories, the inflammatory pain medications or anti-inflammatory pain medications, you've probably heard about ibuprofen, naproxen, meloxicam. Nerve pain medicines, gabapentin, it's also called Neurontin, amitriptyline, also called Elavil, and Lyrica and Cymbalta are the top tier and have the best evidence for treating nerve pain. Muscle pain, we commonly use the baclofen, Robaxin, tizanidine, and cyclobenzaprine. So they all work slightly differently, so we can't say one is going to work for everybody, and that's why we have a whole arsenal of pain medicine and why all these exist. But these are much safer to take long-term than opiate pain medications. Opiate pain medications are still used quite a bit for short-lived pain. So if there's a severe flare-up, well, it's okay to use opiate pain medications like hydrocodone or oxycodone, but we need to have an endpoint. I did put one example of injections that we can do. Probably most commonly the injections that I would do for Ehlers-Danlos hypermobility type or after Chiari decompression is if somebody has a lot of trapezius muscle spasm and pain there. We can go in with what's called a trigger point injection, and we go in and numb with numbing medicine. But the main goal is to break up these bands that form these trigger points, and they're bands of muscle tissue that can cause significant amount of pain. There's lots of other injections we do, such as steroid injections for sciatica, and lots of injections we do, especially on the adult pain management world. But for specifically related to this talk, there's not a whole lot of injections per se. So Ehlers-Danlos Syndrome hypermobility type, which used to be called type 3, is the most common thing I see in my pediatric pain management clinic. And it's a classic disorder of being not diagnosed until very late. It's hard to pick up. A lot of times it has just general muscle aches and joint pain associated with headaches, abdominal pain, dizziness and fatigue, poor healing and bruising. Of course, there's a strong correlation with Chiari. I put this picture of the dog up here because he has Ehlers-Danlos, because you do get sometimes easily stretchable skin. And apparently there's a high rate of this in dogs and in Himalayan cats and in some horses. And I didn't know that until a few years ago. So I put our friend up there. So when we treat Ehlers-Danlos and hypermobility type EDS, we focus on a lot of things I mentioned before. So we really want to focus as the mainstream of treatment a good physical therapist that has specialized in hypermobility. And what we're working on there is joint protection and stability, working on posture, so these joints don't get either more restricted or too flexible, and also teaching what normal joint mobility is. So oftentimes we'll see a gymnast that has been really good in the past because they've been really flexible. But what they've been taught as a gymnast is to be hyper flexible, and that long term that doesn't get us to be in a very good place. So we want to work on what's a normal range of motion with these patients, and again also appropriate bracing and taping. We don't want to leave a brace on too long because in the end that will cause more muscle weakness. And psychology and medications as dictated by the description of their pain. So I really can't finish any pain management talk without mentioning the opiate epidemic and the concern. In my practice, for the last few years, we've been very conservative with giving these medicines, and we should really focus on giving them for short-lived pain, at least at higher doses for short-lived pain. When we look at all the data to support the use of these pain medicines for long-standing pain, there really isn't much. It doesn't, when we look at patients that have been on these long-term and been dealing with pain, they're not really in a better spot 10 or 15 years down the road, and they may have many side effects from these. And everybody that takes these, even for a month, their body gets used to it. And that doesn't mean addiction. Addiction is something entirely different. Addiction means you're using illegal means to get the drugs, and you're using despite the negative effects that they may have. Whereas getting used to the medicine, what we call tolerance, happens to everybody, and that's just a chemical response in the body. Also, another thing that always happens is dependence, meaning if you stop the medicine, you're going to feel worse, and that's a chemical response. That's very different than addiction. So the media will often talk about addiction being a big concern, but it's all these things that should be concerning. And actually, addiction is still relatively a small amount of the patients that take these. But there's other problems with it as well. We know if we give high doses, it will affect breathing. It'll cause hormonal imbalances long term. And one of the most concerning things to me for patients that have been on these, we now know over the last 15 or 20 years that they will increase pain over time. So if you're on these a really long time, what happens is the good parts of the body it works on, where it dampens down pain, well, they get saturated and that's not working anymore. But from the very first time you take one of these pills, there's a small part that increases the pain. That becomes the overwhelming factor with time. And that fancy word's called opiate-induced hyperalgesia. But in general, what that means is taking these medicines long-term can increase the pain. This is why that the U.S. keeps talking about this as an epidemic. The United States uses twice as much as even the next country, Canada, and a much larger amount than any other country in the world. And more concerning is the deaths due to overdose of opiates has skyrocketed since 2000. And this just isn't the illegal opiates. This is the fentanyl, the oxycodones. So this is the concern from the CDC, and while appropriately they're saying we should be really cautious with these medications. This just came out last week from the CDC, and what it shows is, and this isn't related to addiction, this just is related to being on an opiate or one of these pain medicines a year after starting it. So at especially 5 to 10 days, you're at increased risk to be on it at a year. So it is a high-risk medicine if you're on it for a couple weeks or a month, that you may be on this even more long-term. And the reason that's important, even if we put the addiction and misuse aside, is that the more medicine that's out there, that's more medicine in cabinets that are easily accessible to teenagers and things like that. There's also a recent report that a national survey that 1 in 10 high school seniors have used an opiate pain medication illegally, meaning there was a prescribed opiate from grandma or mom or dad, and they used it for a non-medical use, so 1 in 10. So I didn't mean to end on such a negative note, but I also because one of the things, and I think as a patient, I would have this question too, if you had an opiate pain medication after surgery that worked so well, then why don't we just keep prescribing that? Why don't we just keep giving that? It's for all those reasons that I just mentioned. It doesn't get us very far in the long run. So it's always better to focus on all these treatments, because we want to improve the life of the patient. And by just giving them one medicine, that usually never gets us there. We need to focus on increase in the physical activity, getting you back to those things that you find enjoyable, getting you back to socializing, whether that be school or work. So we really want to focus on all these areas and not just focus on the magic trick or to improve pain. And we also need your help, the patient's help to improve. We know that if we're not getting families and patients to do exercise and try to at least gradually build up and do more despite the pain, that we don't make much progress. So we can give you the tools and a lot of help and be happy to keep seeing patients to work through difficult times, but without the patient's help, we just don't make much progress. But we are here, and we're happy to talk through anything with patients. Like I said, I see pediatric patients here about 5 days a month. This is our pediatric pain clinic. I also still have an adult pain clinic, and there's a lot of adult pain providers around the community. So I want to say thanks for hearing me out and giving me time to talk to you today, and I'll be happy to take any questions.
So I've been seeing somebody over at Barnes in the pain clinic ever since I had surgery, so over 4 years. Do you think you ever get to a point where it's just, sorry, you're just going to be in pain, I can't do anything else?
So I think it's tough. We see a lot of patients that there is a point that we may say, you know what, there may be some amount of pain that always exists. And that's very difficult to come to terms with. But I also want to spin it a little optimistically. That doesn't mean we can't keep trying different strategies to make the pain better, even though it may not go all the way away. And at that point, we also don't want it to, even though it may be significant, we don't want it to slow down your life. And so whatever mechanisms we need to give to improve different aspects of your life, even if it's slowly, that's what we want to focus on. But that, unfortunately, is the reality of long-standing pain, is that sometimes it just persists. But our goals as pain management clinics, and that's why it's always called pain management, because we see a fair bit of patients that pain just doesn't go away, because there's often not a cure or a single thing that we can do. But the reason it's called pain management is because we can pull all these strategies and try to improve your daily life, whatever it may be. And if there's a snag or a flare-up, well, maybe we need to refocus things and try and improve from there. But you're right, the reality is sometimes there is a low level of pain or even a significant amount of pain. That's just more reason to pull from these other strategies and keep focusing on multiple different areas and not just one.
You suggested that cognitive behavioral therapy is one of these other effective strategies in managing pain. Even though I have a background in psychology and I know that I studied that at some point, I can't remember a single thing about it. Can you tell me exactly what it is, and then let me know, for example, with a Chiari headache, what would be an example of cognitive behavioral therapy that you found effective?
Sure. My first disclaimer is I'm not a psychologist. So I should have said this from the get-go. We have, most robust pain centers have a psychologist built in the pain clinic. So our adult pain clinic has a pain psychologist, and that's the majority of her practice, is that she sees patients dealing with long-standing pain. In our pediatric clinic, we actually have the luxury of every patient that walks through the door sees our psychologist and our physical therapist that have expertise. So I forgot to mention that, and that reminded me. So what cognitive behavioral therapy is really robust, and I'm just going to hit a couple of high points because there's a lot of different factors that they pull in. One is, like anything in life, we learn to avoid things that disrupt it or that are painful. So what they're trying to do from a general standpoint is change that thought process. So say sitting through class all day long really hurts. And so what happens then? Well, then I don't want to go to class because I can't concentrate, I can't get through it. So how do we change to go about that? Well, one is starting with changing what you're thinking. What about it is painful? Is it the fact that you're in a certain position for a long period of time? Well, let's not look at that negatively. Let's look at how can we put a positive spin and fix that problem. So does that start off with, well, let's try and get through school, but have an excuse to take breaks, to get up and walk around, and change the way we think and avoid things by coming up with different strategies. It also pulls into the idea of how much stress within the family or other things that can cause depressed mood is affecting that avoidant behavior and optimizing that. So if there is a lot of family stressors, of course that's going to affect mood, but it's also going to affect pain, and working on that. So that is just a very general piece of cognitive behavioral therapy, but that's reversing the negative thinking is a very important part of it.
What about unexplained constant stomach pain?
Yeah. So abdominal pain I see quite a bit of, and usually people with abdominal pain that have been dealing for a while they've had an extensive workup, they've had lots of tests done, and then there's just no cause. What we know about pain in general is everybody is so unique that their nerves are sometimes they're developed to be more sensitive, and for that reason they get revved up when other people wouldn't have long-standing pain. And sometimes there's nothing to go in to fix with abdominal pain from a surgery standpoint or a procedure or a medicine standpoint. But again, that's why we use all these different strategies. And so while the pain may exist, we know that if we focus on boosting up activity but working with psychological therapies to overcome some of these obstacles, that's where we make our best effort. From a pain management standpoint, there's many times that we don't have a diagnosis that we can pinpoint that this is the cause. We can always give it a term, that says, okay, this is functional abdominal pain is one of those words. But in my mind, what's more important is to get you back on track and to improve the quality of your life, and not wait for the magic cure for the pain to get better, but start going after these strategies to improve things. Now, if something comes up and we identify something that can be fixed, of course, we want to go after that. But we don't want to, from a pain management approach, it's different than other specialties. We want to capitalize on all these treatment strategies and not just let the pain kind of take over our life.
Right, but I guess what I'm specifically getting at is my 5-year-old has the Chiari, and we're still in the process of the different tests and stuff. I don't want him to feel like, as the mom, you want to be able to take away the boo-boos and stuff, but I don't want him to feel like mom can't help, because Tylenol doesn't help, Tums doesn't help, ice packs, nothing is helping. And so I don't know what else to do.
Yeah, I think when things like that exist, probably seeking out a pain management specialist is the best.
Is that something that my pediatrician would recommend, the neurosurgeon?
Absolutely.
Any of them?
Yeah, any of them. Where are you from?
We live in Union, Missouri, which is in Franklin County. And
yeah, that's where I'm from.
Oh, Union?
Yeah.
Oh, seriously?
Yeah.
So, we do physical therapy and massage therapy right now at the Mercy Clinic right behind Dairy Queen, as you said, from Union. And he does speech therapy twice a week with Walker Rice Scotch Center and stuff. But, it's just... he's on Topamax for the chronic migraines right now, and he has his full spine MRI coming up and things like that. But in the meantime, it's he's constantly having stomach pain and the leg pain and feet pain. The physical therapy and massage therapy is helping with that, but the stomach pain is the only thing that's not being addressed or helped with
Sure.
whatever is being tried.
I think when that's going on, I think you ask for a referral to a pain management specialist. And when all this stuff is done, and I don't want to say piecemeal because it sounds like you got good physicians that are trying to take care of things and get things better. But when you're not kind of in an all-encompassing clinic, it's harder to pull these things together to get better. And the physical therapy is not all the same, and different types of therapy are not all the same. When you see somebody that has specialized, like our psychologist or like our physical therapist, we tend to make better progress just because what we see. So when you say, something flared up, we tend to have a few more treatment strategies to use. There's a few pediatric pain centers in the country, basically. There's 40. And there's one here, one in Kansas City, and one in Chicago. So Union being about 45 minutes away, I can give you a card and you can give it to your primary care doctor and they can make the referral, and then we can try that. That's not a problem. That's what I'm here for.
Yeah, like I don't have a problem, like, and I actually homeschools, and it allows for his bad days and things, and then also, you know, with the scheduling appointments and stuff. But with those things being frequent throughout the week, I have those things in Union, everything else I have up here.
Yeah. No, it's a tough problem.
So I get a card from you?
Absolutely.
Okay, good.
Yes.
I'm struggling to tease out what of my various, like, somewhat mild issues are related to Chiari versus just their own issue, you know? So, like, the list of things that you had there for the Syrinx and whatnot, like, well, okay, they're all there, and the neurosurgeon says surgery, and the neurologist says, nah, that's all this and that and something else, and it's not the Chiari. So I'm trying to figure out, you know, well, in my head, am I over-dramatizing, whatever, you know, that's what I'm kind of confused about.
Yeah.
Because I'm trying to deal with them all separately,
Yeah.
best I can.
I guess our approach is just a little bit different. First of all, whenever something is affecting you, there's a few red flags. If it's affecting your life and really disruptive to you, then I think you need to change a treatment strategy. And that's not saying go for an invasive procedure. However, there's always a role for surgery. I'm not a surgeon, but there's definitely immediate concerns. You know, of course, if there's weakness or you have a lot of numbness that has really increased, well, that's reason to talk to the surgeon again. But outside of that, we need to hear from you kind of how disruptive this is, and then I'm treating more symptoms and trying to get you through that than a specialist in neurology and neurosurgery would do, where they're looking at the side of the problem, which is we need both. Okay, we need them to be able to try and offer therapies that can really alleviate the problem while we're trying to go more from the symptom approach. I hear what you're saying. Well, is this causing it? Well, if I did have surgery, would it alleviate all these symptoms? And as somebody that's not a surgeon, I don't know. I probably can't answer that best. But in my mind, I want to treat the pain symptoms you're having through these different approaches and focus on that. And again, even though this stuff may be from a neurologist or from a neurosurgeon, may be either going to happen in the future or not happen, we don't want to slow down progression from a pain management strategy while we're waiting for those things to happen. But it's tough. Are all these symptoms interlinked? Sometimes they are, and sometimes they're different things altogether. Yes.
I have a question, and this might sound kind of crazy, I don't know. So I was looking at the list of some of the medications. I guess they were inflammatory and neurological, and
Yeah.
a lot of them I take currently. I think I had something from every list. I think there were 4 different categories. I think I had one, except from the opioid. I think I had something from every list. Now, those are medications that you would administer in pain management?
Yeah, those are the common ones that we typically start to. So I put those up there because they do have what we call medical evidence to support them. And just as importantly, even though there's side effects associated with them, they're actually typically pretty mild for most people, and they don't have many drug interactions. They don't cause problems interacting with other drugs. And the important part is taking most of those long term won't have many side effects. So those I definitely don't prescribe all those to everybody all at once. I don't do that. And typically my approach is whatever I think is the biggest component or type of pain, that's where I start. I may add one from another category or switch up one with time, but I don't even. Some pain physicians will start a few at a time. My approach is maybe 1 or 2 and see how things go. So if you start a bunch at a time, well, if you get a side effect, which one was it? You know? Or if one helped, which one was it?
Okay.
I have a question.
Yes.
And I can never pronounce that muscle right.
Trapezius, yeah, you got it.
Yes, that muscle. When you talked about with physical therapy and you get back to where you're somewhat at normal, the new normal state, you get the pain under control, that muscle gets under control. What makes it keep coming back?
It's so, I like to blame the muscles a lot, and mainly because I think even though they may not have been the origin of the cause of pain, they definitely get flared up and oftener because what lingers around. It's basically because they're involved with all movement, especially if we have EDS or Chiari or something like that. Anything that is disrupted below that, they just spasm and tighten up. So it can be anything. It can be, I think we've all probably had a muscle cramp or pain. It could be twisting or turning, and it could just flare back up. And the trick is, if it is muscle, is not to spend too much time letting it just heal on its own without movement, but to go after trying to stretch it out again. Too. I don't know if that answered your question.
It did and it didn't. So when you get back to normal state, and I'm talking about Julia, she gets these huge flare-ups where this big knot occurs back there, and we don't like the opioids or any heavy medication, so she does ice, heat, but then she gets back to normal state where she's doing her athletic type activity, but then 2 months later, bam, and it really takes you down when that happens. So I'm confused of why when you get back to normal state and the muscles are continually stretched and strong,
yeah, why
does it just come back by itself?
Sometimes it can just be the individual, the way you're born, the way your genetics have been made you up, and that it can be just small. It could be the same movement you've done 1,000 times,
yeah,
but for some reason it torqued that muscle just a little bit different that day that flared it up. And sometimes you can't pinpoint what that actually was. But probably more importantly, well, what do you do for that to prevent these flare-ups? So if you're active and you're doing what you're doing, and it sounds like keeping you strong, then that may be a reason to do a low-dose medicine. Or if it does flare up, things like TENS units, you may have even tried that before. The TENS, T-E-N-S. It's probably somebody in the audience. Yeah, it's transcutaneous electrical stimulation. Sounds much scarier than it is. What it is it's just a little. It almost feels like a little vibration. What it's doing, it's little stickers you put on, and physical therapists often do it. But that can relax the muscle in itself, and that doesn't have any side effects. Is the other advantage of it. But the other flip side of this is also just talking to somebody that has seen muscle spasms a lot. And there's a lot of safe medicines. I hear that you don't want to take any heavy hitter medicines, but sometimes a muscle relaxant in the background may make those flare-ups less. Or when they do happen, an as-needed muscle relaxant may make a flare-up shorter.
So are there over-the-counter ones like that, or do you have to? You think by the time you make it,
Amazon, Walmart has them.
Oh, the TENS units, yeah.
oh, they have those at Walmart?
Yeah, you can order the TENS units on Amazon. But you're talking about muscle relaxants. There may be some herbal supplements that advertise them as muscle relaxants, but nothing that necessarily is a specific muscle relaxant category.
Because by the time you make an appointment with the doctor, and that's weeks out, when schedules match, then it's gone, because we've done that.
Yeah.
And then we go, and it's like, oh, seriously, I got a picture of it on my phone. And I'm trying to show him, and it's like, come back when it's like that. Well, I can't predict when it's going to, so it's this kind of chase we're doing associated with that.
Yeah, and my best advice is, even though you're doing it because it flares up and you want it to get better for that flare up, maybe going in before, even if not at a time of flare up, and coming up with a treatment plan with the medicine that you have available. So still keep the appointment, I guess.
But who do you do that with?
Who do you make the appointment with?
Yeah.
Pain management physician, or sometimes sports medicine will.
So you can just go to a pain management doctor and say, I'm having these. You don't need a referral to go.
You do need a referral. What I'm saying is, in this case, I would not make it a reaction to the flare-up. I would start pursuing a referral now, and even know that it's not flaring up, so you'd have something to do during a flare-up, and not make it reactionary, but just go not during a flare-up. That way you have a treatment plan when it does happen, and you don't have to wait for it to flare up and try and get back in.
That's good feedback. We had that and recommended. That's a good thought.
What about certain types of massage things? Because like you were talking about like the pain in the neck and the shoulders and things like that. from our massage therapist, like basically you have to go with the grain of the muscles when you're rubbing and stuff. And a lot of times if your shoulder's hurting, you're just doing this, it actually tenses the muscles up more and makes it hurt even more because it's not the right, technique, I guess. So like, would that be something like mom could
Absolutely.
rub it a certain way?
Yeah.
Like,
When they're not come, you can't touch her.
Yeah. So I also never want to downplay I didn't mention massage therapy, acupuncture, just because I'm not an expert in them. But there's a reason all this stuff has existed for a long time and it's helped a lot of people. So I encourage everyone, if we're not making progress from these traditional strategies, that just ask the physician you're seeing, because most of the time somebody asks me about acupuncture massage, I will never negate it. I'll say that I don't have medical journals to say that this supports it, but anecdotally I know plenty of people have improved from it. But I would, if you start asking me many more questions about massage therapy, you'd quickly realize I don't know much about massage therapy or acupuncture.
But is that safe to know to have those cycles, to have a cycle with, in her case, with that muscle, and just do it a lifetime?
Yeah.
You know the cycle.
Yeah, so I went to arthritis doctor and he prescribed trazodone, so you can't take other muscle relaxants as needed. So when my back spasms badly, I have it. And then my regular doctor re-upped the prescription. So that's just an as needed. So when I get a spasm that's really intense, I have some.
A lot of patients that I've seen, we do that. They come to us and I don't have any pain today, but that's okay. I'm glad you're not having pain. But that doesn't mean we can't give you something for when it flares up. And there are as needed muscle relaxants. Yes.
And so when you say ask your doctor, it's so difficult to do that because so many doctors, I've been in the ER and they say, what do you have? And you're explaining to doctors and nurses what you have. They don't know. So sometimes that's really hard when you feel like you know more than they do and you don't feel like you know much. But I was curious your opinion, going back to the trigger point injections. So anytime you do something, cut something or use a needle, like you're creating some amount of scar tissue. So is that just a balance of the risk versus the benefits?
Yeah, it's all related to how big of an area you're going into and what you're going in with that causes scar tissue. So the smaller thing that you use, the less injury. We can get scar tissue without it, of course, an incision or a needle too, and
Right.
muscle spasms and these tight bands may be, you can kind of consider that a type of banding like scar tissue. So yeah, I do trigger point injections for people really struggling. Do I think they're the miraculous cure for anything? No. I'll do it as if these other strategies aren't working to try and get somebody over the hump. Because in reality, what we're doing is we're just trying to go in and break up that band. But they've really fallen out of favor. I think they're good when things flare up, but by no means do I think they're it. That's what we need to be doing.
And
some people don't.
Several different kinds, and they've never.
Yeah, and they're highly variable. That's just like you said. Some people get great response, some people don't get any response. So I really reserve them for things that something to try if none of this other stuff is helping out too much. All right.
I have a comment. When you were talking about the psychological aspect of it, we had to do that because pain medicine wasn't enough for Julia. We had to do that, and we asked for a referral because we were just at our wits' end. But I was going to say, regarding the physical therapy aspect, that made her more depressed going to physical therapy because it was the flare-ups and it was like a cycle back and forth. I'll tell you what did help, and I tell anybody this, and it was ballet because it gave her something, and it goes back to the mind and the emotions. It was something that was fun or deemed to be fun. It wasn't you know, she was the less skilled person there because of the, you know, recovery, but it was fun, and all the posture and the correct form of the body and all that was being dealt with, and that helped her recover better than she was doing in physical therapy.
No, I think that's a great point. I think you got to find what works best for you.
Yeah.
I'm glad you found it in that case. I also say not every, just like there's specialists in the medical community, there's specialists in the physical therapy community. So not all physical therapy is the same. In the community, physical therapists are really good at treating ACL tears and joint replacements and things like that. They haven't always seen somebody that has a lot of the muscle pain or pain from Chiari or Ehlers-Danlos, and so it's hard to find those. But if you ever have questions, if you go ask a pain management specialist or even a hospital, they usually will be able to give you, because we have physical therapists that specialize in hypermobility syndrome, for example. All right, well, thank you, everyone. Thanks for giving me time today to talk.